Hi guys, welcome back everyone to the Reed Harrison series. Today we're going to take up a very important topic, that's meningitis. All of you would have seen cases of meningitis in your wards during your postings, or you would have at least studied or faced questions about meningitis. Today we will learn finer details about it. So let me begin with the first question. What is meningitis? So when we talk about meningitis, we know that it is inflammation of meningeal layers. You know that we have meningeal layers, pia matter, dura matter, arachnoid matter. So the inflammation of these meningeal layers is what we call as meningitis. Now, can there be meningitis without infection? Yes. Meningitis can be infectious or non-infectious. Can you give me some examples of non-infectious causes for meningitis where there is no infection but you still have meningitis? Yes, of course, I agree. Infectious causes are much more common than non-infectious, but you can still have non-infectious. I can give you a few examples. Meningeal carcinomatosis. Then we can also see meningitis in patients with rheumatoid arthritis, SLE, and other immunological disorders where meninges are inflamed without any infection. Because in these immunological disorders, there is formation of inflammatory cytokines which are targeting multiple organs, and meninges is just one of them. Like, for example, rheumatoid arthritis, you develop pericarditis, peritonitis, pleuritis. Similarly, you can also get meningitis. Infectious meningitis is a far more serious disease with very high mortality, particularly when caused by bacterial, fungal, or tubercular etiology. That's why our focus will be on infectious meningitis. And infectious meningitis is way more common than non-infectious meningitis. So in that case, when it comes to the infectious meningitis, what are the common causes? The causes for infectious meningitis can be divided into bacterial, viral, fungal, and tubercular. Fungal and tubercular. Now let's first begin with the bacterial meningitis. What are the important causes for bacterial meningitis? The most common cause for bacterial meningitis, which accounts for more than 50% of all cases of meningitis, is Streptococcus pneumoniae. The most common cause for bacterial meningitis is Streptococcus pneumoniae, or you can call it as pneumococcus. Streptococcus pneumoniae, that's the most common cause. The second most common cause, accounting for another close to 25% of cases, is going to be Neisseria meningitidis or meningococci. Neisseria meningitidis or meningococci. In the recent times, there is a surge of another bacteria, you know about it, and that is right now the third most common cause in many countries, and that's going to be another cocci, Staphylococcus aureus or Staph aureus, as we all call it as. And when we are talking about Staph aureus, we know that there is a rise of methicillin sensitive and methicillin resistant cases both. So it could be MSSA or MRSA. These are the three most common causes for the bacterial meningitis. Why am I emphasizing on this? Because going forward, we have to take a call about antibiotics, and whatever is the case, when you're initiating an empirical antibiotic without getting the culture report, you should keep in mind that these are three most common organisms and your antibiotics have to cover them. Without covering these antibiotics, we are not, without covering these organisms, we are not hitting the root cause. Okay, so these are the three common organisms. Apart from that, under certain circumstances, other organisms become an organism of concern. They're not routinely causing infections, but under certain circumstances, they become significant organisms. So when it comes to the bacterial meningitis, apart from the three common that we just discussed, I want you to remember that there is one organism called as Listeria monocytogenes. Listeria monocytogenes. Now, this generally is not a routine cause for meningitis. I should not be suspecting this organism in everyone with meningitis. Then what should prompt me to suspect Listeria monocytogenes? This is a concern in two sets of patients. It's a concern. Usually Listeria monocytogenes affects the extremes of the age, newborns and elderly. So it's a concern in patients aged more than 55 years. Of course, newborns also, but the pediatrics, I will leave it to the pediatrics faculties to address about it. But when it comes to an adult, I should be concerned about Listeria monocytogenes if I get a meningitis patient who is aged more than 55 years, or if there was a recent hospital exposure or hospitalization. Hospital exposure or hospitalization. A patient was hospitalized recently or had a history of hospital exposure. For some reason, multiple hospital visits were there. Then the patient might have acquired this organism from that source, that is hospital. Then there is a second organism which is of concern, not in every other case of meningitis, but in selected circumstances, that is Pseudomonas aeruginosa. Pseudomonas aeruginosa. If you already completed the second MBBS, you must be knowing that Pseudomonas aeruginosa is more or less a hospital acquired infection. So patients who had exposure to hospital in the recent times, if they present with meningitis, I should also keep this organism in mind, and whatever antibiotic I'm going to choose should be covering this organism as well. So Pseudomonas aeruginosa is a concern if I'm thinking about. It's not a routine concern for every patient of meningitis, but I should be concerned about this organism if there is hospital exposure or hospitalization. Hospital exposure or hospitalization. And again, someone may acquire Pseudomonas aeruginosa infection not routinely in the like what would I say, in the community, but if there is a penetrating head injury, then these organisms, they are there in the atmosphere, they are ubiquitous, they can be inoculated into the meninges directly, and then someone can get that. Otherwise, most of the patients acquire Pseudomonas aeruginosa in the hospital. So it could be hospital exposure or hospitalization. And at the same time, I should be concerned about this in patients with penetrating head injuries. In patients with penetrating head injuries. Or in simple words, you can say open head injuries. So let me summarize again. The causes for meningitis could be bacterial, viral, fungal, or tubercular. Among the bacterial, the pneumococci is the most common cause, followed by meningococci, followed by staphylococci. These are common organisms. But apart from that, selected individuals are prone to develop infections by some not so common organisms like Listeria monocytogenes if the individual is more than 55 years old or he had exposure to hospital recently. Similarly, Pseudomonas aeruginosa if the individual had hospital exposure or hospitalization recently, or if there was a penetrating head injury. Now, based on this context, repeatedly MCQs are being asked in the NEET PG exam. They give the context that this is the age of the individual and this is the context, whether there was hospital exposure or not, and then they will ask you to suggest an empirical choice of antibiotics. So whatever we are discussing today, this is the most important part. These are the three most common organisms, and these are two additional organisms that I want you to remember. Okay, now going back, there could be viral causes. We don't have to remember the names of the viruses. Literally, you name a virus, it can cause meningitis. Then fungal meningitis. When it comes to fungal meningitis, what I want you to remember about fungal meningitis is, number one, it is more common in immunocompromised individuals. Important organisms that you need to remember is Cryptococcus neoformans. Cryptococcus neoformans. Then this, I think all of us have enjoyed doing the India Inc. prep. Neoformans. Then coccidioidomycosis. And other rare fungal infections. Particularly for the exam, this Cryptococcus neoformans is an important question, and this is the most common cause for fungal meningitis. So just like how we learned that these organisms typically affect select set of patients, similarly fungal meningitis occurs in select set of patients. So what are the risk factors? A healthy, competent individual, immunocompetent individual is unlikely to develop fungal meningitis. Fungal meningitis typically occur in individuals who are immunocompromised. So we should suspect fungal meningitis in immunocompromised individuals. When do you say someone is immunocompromised? Don't merely say HIV. That's not immunocompromised state. Good evening. Good evening. So HIV with CD4 count less than 200 per cubic millimeter is when you can say, he is reasonably immunocompromised. In the era of highly effective antiretroviral drugs, we are not very often encountering these values, right? So not everyone with HIV is immunocompromised. When the CD4 count is less than 200, yes, there is a risk of developing cryptococcal meningitis. Second, poorly controlled diabetes is also emerging as a risk factor. When do you call it as poorly controlled? Well, there is no standard definition for poorly controlled diabetes, but in practice, we notice that when their HbA1c for a very long period is more than 10. Third, patients on immunosuppressants or cancer drugs, patients on immunosuppressants. When I say immunosuppressants, it includes the corticosteroids as well as other non-corticosteroid immunosuppressants and cancer chemotherapy. Now also remember that patients of cancer who are not receiving chemotherapy are also immunocompromised and they are also prone to develop fungal meningitis. So now, when do I suspect Listeria monocytogenes meningitis? Elderly, newborns, and patients with hospital exposure or hospitalization. When do I suspect Pseudomonas aeruginosa meningitis? Hospitalization or hospital exposure or patients with penetrating head injuries. When do I suspect fungal meningitis? In patients with immunocompromised state. These will be counted as the risk factors. Okay. Now, tubercular. As such, in India, tuberculosis is very common. But as a doctor, I should know when should I start suspecting tubercular meningitis. So most of the patients with tubercular meningitis may already have tuberculosis elsewhere. In the sense, there may be already a case of pulmonary TB or TB in other organs. That is first point. Second, if there is history of contact with an open case of TB, tuberculosis, we should be suspecting tubercular meningitis if they present with signs of meningitis. So if the patient has got, so this is quite common in India. So in the Western world, they suspect it if there is a close contact with the open case of tuberculosis or a patient already is documented case of tuberculosis elsewhere. In India, tubercular meningitis will remain a differential diagnosis of any patient presenting with subacute to chronic meningitis. Now, all these patients, be it bacterial, viral, fungal or tubercular, what symptoms they bring to hospital? How do they present? More than 80% of the patients of the meningitis present with what is called as meningitis triad. More than 80% present with meningitis triad. So it's not very difficult to suspect meningitis. It's pretty easy. Okay, what comes under this meningitis triad? The common symptom that brings them to the hospital is headache, fever, and nuchal rigidity or neck stiffness. One extra point I want you to note. By the time you see these points, you already know that the question, examiner or the patient is talking about meningitis. But the extra point I want you to know, like we just spoke about HIV presenting with fungal meningitis, right? Or cancer patients or patients on immunosuppressants or patients on steroids presenting with fungal meningitis. Many of them may not have the fever or the headache because the inflammation is being suppressed by the steroids or the immunosuppressed state itself. So the absence of meningitis triad does not rule out. So this is the first point I wanted you to note. And the second point is absence of meningitis triad does not rule out, or in simple words, I would say absence of meningitis symptoms does not rule out meningitis. So many a times to diagnose meningitis, we need to have a very high index of suspicion, investigate with a lumbar puncture, and then you will be able to pick up. So absence of meningitis symptoms does not rule out meningitis. If symptoms are there, well, the case is unfolding itself in front of you, but if it is absent, it does not rule out. Okay. Now, if I am suspecting, what examination findings we are going to get? All of you are familiar with what is called as Kernig sign and Brudzinski sign. But can you tell me, are these signs specific for meningitis? Will I not get them in any other condition? We call them as Kernig sign and Brudzinski sign. Kernig's and Brudzinski sign. These are not the signs specific for meningitis. These are signs of meningeal irritation. These are signs of meningeal irritation. Now, what do I mean by that? Regardless of the cause, if the meninges are irritated, we will be able to elicit these signs. So, in what other condition meninges can be irritated where there is no meningitis? Meninges are irritated, but there is no meningitis. Pretty common. We do encounter these patients every now and then. So, well, remember, subarachnoid space is part of the meningeal layers. And if I bleed into the subarachnoid space, what you call as subarachnoid hemorrhage, there also meninges are irritated, but they are not infected. They are not inflamed. So, there is no meningitis, but meninges are irritated. If cancer spreads to the meninges, meningeal carcinomatosis, there is no infection or inflammation, but meninges are irritated. There also you will find these signs. Then how will I differentiate whether this is subarachnoid hemorrhage or the meningeal carcinomatosis or truly meningitis? Well, the context. That's why in medicine we keep saying that history is the most important thing. If someone presents with a complaint saying that, sir, I'm going through the worst headache ever in my life, and then you get the signs of meningeal irritation, then you know it is probably subarachnoid hemorrhage. If someone comes with fever, neck stiffness, headache, and you get the signs of meningeal irritation, the context is pointing towards meningitis. If it is a known malignant tumor elsewhere, which is known to metastasize to meninges, and then he comes to you with the neck stiffness, then you know that it is the cancer spread. So context takes you to the diagnosis. Examination findings, we are seeing what we call as signs of meningeal irritation. Signs of meningeal irritation. And as I have already told you, these are not specific for the meningitis. These are signs of meningeal irritation. So the first sign that we are going to study about is called as Kernig's sign. So like you may be familiar with another sign called as Brudzinski's sign. Brudzinski sign. Okay. So in both these signs, basically what we are trying to do is the meninges are already irritated. We want to stretch the meninges. And when we stretch the meninges, the irritated meninges trigger pain. And patient does some physical change in himself to avoid further stretch of the meninges so that the pain can be minimized. So the first one is Kernig sign. So in Kernig sign, what we do, we ask the patient to lie down on a bed and then we flex his hip 90 degree and knee at 90 degree. So hip at 90 degree and knee at 90 degree, and then we will further extend his knee. We will further extend his knee. Normally we should be able to go closer to 165, 170 degrees. All of us do this in our bed, right? We can literally raise our legs straight up comfortably. But in these patients, as I try to further extend the knee, the meninges here, like this, spine gets stretched, and as the spine gets stretched, the meninges also get stretched. They are already irritated because of the inflammation, in subarachnoid hemorrhage because of the bleed, in meningeal carcinomatosis because of the cancer spread. They are irritated, and when I try to stretch it further, this maneuver stretches it further, it triggers pain. So patient won't let you further extend the knee joint. So if there is difficulty to extend the knee joint beyond 135 degree, normally comfortably we should be able to go beyond 160, 165 degree. But if there is pain to extend knee beyond 135 degree, then it is highly suggestive of positive Kernig sign. That means the meninges are irritated. And this is our Kernig sign. Then we have one more called as Brudzinski sign. So here we ask the patient to lie down flat on the bed, and here also we will try to stretch the spine. Here we were trying to stretch the spine by manipulating at the foot end. But in the Brudzinski, what we will do is we will try to manipulate, or we will try to stretch the spine by, like, from the head end. We will flex his head. So as I flex his head, the irritated meninges will get stretched along with the spine. That triggers the pain. And to avoid this pain, patient tries to shorten. I have stretched it by flexing the patient's neck. He wants to shorten the spine. How will he shorten the spine? He will withdraw the leg. So I had asked him to lie down flat on the bed, but he will withdraw the leg. So there will be flexion at two joints. Flexion at hip joint and flexion at knee joint. Flexion at a hip joint and flexion at knee joint. So here, what is the input that we gave? Flexion of the neck. The action or input is flexion of the neck, and output we got here is, this is the input, and this part is the output that we are getting, because patient is now trying to, we are stretching the irritated meninges and patient is trying to counter that. He wants to shorten the meninges. So this sign we are going to call it as Brudzinski sign. Brudzinski sign. So your teachers in your bedside discussions may ask you to demonstrate these signs. How do you check for these signs? So how do I check for Kernig sign? I make the patient first lie down flat. Then I will raise his lower limb in a way that hip is at 90 degree flexion, knee is at 90 degree flexion. And then I will further try to extend the knee beyond 90 degree. If I'm not able to go beyond 135, I start experiencing resistance by the patient, or patient starts complaining of pain, Kernig is positive. How do I demonstrate Brudzinski's? I will ask him to lie down flat on the bed and flex his neck. As I flex his neck, the stretched spine means stretched meninges which are irritated. So he will try to shorten the spine by flexing his hip and knee. Indirectly, he is withdrawing his leg so that the spine gets shortened. So these are the two signs of meningeal irritation that we can demonstrate. With this, we have just confirmed that it is meningeal irritation. With the context of fever, neck stiffness and headache, we are considering meningitis. Now at this level, I really don't know whether this is bacterial, fungal or viral. So what investigation I can do to confirm whether this is bacterial, fungal or viral? It is going to be the lumbar puncture for CSF analysis. So the investigation of choice for the etiological diagnosis is going to be lumbar puncture for CSF analysis. But before I do the lumbar puncture for CSF analysis, there is a prerequisite. So the investigation of choice for etiological diagnosis will be lumbar puncture for CSF. Okay. Now before we do this lumbar puncture, we should make sure that the intracranial tension is not very high. Because of the meningitis, there may be already elevated intracranial tension, and the moment I put a needle to do the CSF tap, I can cause the decompression and the brainstem herniation, which can be a reason for patient's death as well. So there is a prerequisite that I have to do, prerequisite or a minimum need for the lumbar puncture. I have to ensure that raised intracranial tension is not there. I have to rule out raised ICT. How do I rule out raised ICT? The preferred method is to do the CT scan of the brain, CT brain or MRI brain, or MRI brain. If that is not readily available, the alternate thing I can do is fundus examination for papilledema. Fundus examination. If there is raised intracranial tension, there may be papilledema or optic disc edema, as we call it as papilledema. Okay, so now that I have got a CT done or fundus examination done and I've confirmed that there is no raised intracranial tension, I'm going ahead with the lumbar puncture for CSF analysis. One of you may ask, sir, what if there is raised ICT? I should not do lumbar puncture at all? No, it's not an absolute contraindication. You can do that, but first start the anti-edema measures, reduce the cerebral edema, bring down the intracranial tension, and then go ahead with the lumbar puncture for CSF analysis. Not when the intracranial tension is high because of the risk of brainstem herniation. Once I have done the lumbar puncture for CSF analysis, the next thing is how do I interpret the CSF report that has come? How do I analyze the CSF report? I will not get into the very microbiological details of the CSF analysis. I'll give you a quick heads up which you can use for solving the NEET PG MCQs as well as your ward cases. How do I interpret the CSF? So in the CSF, first thing I should look for is the cell count. Cell count. What is a normal cell count? The normal cell count in the CSF is usually less than 5. Okay, but in case of bacterial, viral, fungal, it is often increased. Viral, fungal, and tubercular. In all cases, it is usually increased. How much increase we are expecting? The normal cell count is less than 5. So in bacterial, it goes from hundreds to thousands. What do I mean by this hundreds to thousands? It doesn't mean 100 to 1000. I'm talking in terms of multiples of hundreds and thousands. So it may be like 100, 150, 200, 250, 300. So के हिसाब से या multiples of thousands, मतलब 1000, 1500, 2000, 2500. So when you see thousands, most likely it is going to be bacterial. We don't see the cell count in terms of thousands in viral, fungal and tubercular, quite unlikely. So viral, fungal and tubercular, it will be in the range of tens, means 10, 20, 30, 40, 50, 65, 70 like that. 200s, matlab 100, 200, 300, but not in terms of thousands. So if I get a cell count in thousands, it is highly suggestive of bacterial. So there itself I may get a clue. But let us say I got a patient whose CSF shows a cell count of 200. अब ये क्या हो सकता है? What it can be? Can it be bacterial? Yes, bacterial we do see in the ranges of hundreds to thousands. So it can be bacterial. Can it be viral? Yeah, we can see in hundreds. Can it be fungal? Yes, we can see in hundreds. Can it be tubercular? Yes. So now cell count is not helping me because it's falling in the gray zone. So then what I can do to differentiate further? We can look at the differential count. Differential count. We will see which one is the predominant cell. So in the bacterial, usually we have neutrophilic predominance. What do I mean by that? Whatever is the total number of cells, more than 50% of them are neutrophils. So we will have neutrophil predominance. In viral, fungal and tubercular, we will have lymphocyte predominant. Lymphocyte predominant. That means more than 50% of the cells are going to be lymphocytes. So in one of the offline classes, a student asked me, sir, how would I diagnose if I have both the cells more than 50%, neutrophils also more than 50% and lymphocytes also more than 50%. So I was in the flow of the class and even I was taken aback. Okay, what if both the cells are more than 50%? But then I'm like, इतना तो maths में भी जानता हूँ. How is it possible that two sets of cells are more than 50%? If one is more than 50%, by default, other will be less than 50%. Like let us say neutrophils are 51%. Then lymphocytes have to be 49%. They can't be like 51%. Both can't be more than 50%. So we'll easily find out which one is predominant. So if it is neutrophil predominant, pointing towards bacterial. So in the beginning, I gave you an example. Cell counts are 200. Now, out of the 200, let us say 120 are lymphocyte predominant. Now, what it can be? Like 120 are lymphocytes. 200 is total cells. So, more than 50% cells are lymphocytes. So, it can't be bacterial. So, from the equation, bacterial is already ruled out by looking at the differential count. So, now I am thinking about viral, fungal or tubercular because all of them have lymphocyte predominant. Now, how will I evaluate further? We can look at the protein. In medicine, we don't give too much value to the CSF protein. The normal CSF protein is usually less than 45 milligrams per deciliter. It is less than 45 milligrams per deciliter. So it is usually significantly increased in bacterial, fungal and viral, in tubercular. In viral, it may be increased or sometimes minimally increased or normal. So again, as you look at this, yeah, you have more higher values of protein in bacterial and tubercular in comparison to fungal and viral, but they don't help you to rule out or rule in. So then what is going to be really useful next investigation, that is going to be CSF glucose. Now the CSF glucose that we're talking about is not a fixed number. Like I said, cell count is less than 5, protein is less than 45 milligrams per deciliter, but CSF glucose is a function of blood glucose. If you already have high blood glucose, your CSF glucose will also be high. So that's like the normal for CSF glucose is decided by the normal for the blood glucose. So if the patient blood glucose is already high, then CSF glucose is expected to be proportionately high. So it is normally 60% of, you can say 2/3 or 60% of blood glucose. So let us say that I am dealing with a person whose blood glucose is 120 milligrams per deciliter. So what should be the CSF glucose? It is roughly 60%. When it is less than 60%, you can say it is low. So how much is the blood glucose? I said blood glucose is 120. In that case, what should be the CSF glucose? 60% of this is the minimum CSF glucose that I want to see. So 60% of 120 is 72. So for CSF, the normal for this individual is 72. If it is less than 72, it is low for this particular individual, right? If blood glucose is 200, then how much is the normal CSF for this individual? 60% of this 120 will be considered as normal for the CSF. So if it is less than 120, then it is low, right? So that is how we are going to decide. Now I gave you an example of a case. Let me write down the values that I had mentioned you. So value that I had mentioned you are cell count was 200. Cell count was 200. Then it was lymphocyte predominant. Out of this 60% were lymphocytes, 120 were lymphocytes. and then protein, let us say it is 200 milligrams per deciliter. So it is increased but doesn't help me to rule out. When I say lymphocyte predominant, we are not considering bacterial anymore. We are thinking of other possibilities, viral, fungal and tubercular. Now CSF glucose, right? CSF glucose, here let us say the blood glucose is 100 and CSF glucose is 0, not detectable. Okay, so what it could be, let us see. The CSF glucose is usually decrease, yes, sometimes not detectable or as low as 0 in bacterial. It is usually normal in fungal, viral, sorry, and it's also usually normal in fungal, rarely low in fungal, rarely decrease in fungal, and tubercular it is often decreased. So now tell me two subtypes of meningitis where we have profound decrease in the CSF glucose, bacterial and tubercular. Bacterial and tubercular. Why in bacterial? Because the bacteria are rapidly replicating and the glucose gets utilized for their replicative process. Why low in tubercular? Tubercle bacilli are not rapidly replicating, but to contain the tuberculosis infections from spreading outwards, we create granulomas. Granulomas are formed by macrophages. So you can say that tubercle bacilli spread outwards is stopped by a colony of cells, which we call as a granuloma. And this colony of cells are actively combating against the bacilli. So they need energy. So they utilize the glucose, and that's why CSF glucose will be low in tubercular. So in tubercular, tubercle bacilli are not using the glucose. It's our own macrophages which are forming the granulomas. In case of bacterial, it is a bacteria which is utilizing. The viral replication does not utilize much energy because viral replication includes what? It's DNA or RNA and a capsid. It's not making a whole cell. So we don't need much energy. So we don't use much glucose. That's why the CSF glucose doesn't get depleted. Fungal replication, yes, it involves the formation of whole cell, but the replication is low. So we don't end up having low glucose. So now here, what do you think it is likely to be? Cell count 200, it could be anything. But then the moment I see lymphocyte predominant, it is unlikely to be bacterial. It is fungal, viral or tubercular. Next thing I see protein. Protein can be raised in any of these. So here it is raised, doesn't help me rule out anything. But when I look at the CSF glucose, the blood glucose is 600. So CSF glucose should be 60 or higher to call it as normal. Anything less than 60 for this patient is considered low. Here it is 0. So it is low. So the story is pointing towards tubercular meningitis. So this is how we are going to interpret the CSF. Okay, so if you have that clarity about it, let me also give you some additional clues when you should suspect fungal meningitis, when you should suspect tubercular meningitis based on the CSF report. So if it is tubercular meningitis, the additional clues, right, the additional clues you are going to get for tubercular meningitis, apart from the history of tuberculosis elsewhere or coming in contact with a case of TB, there also be a mention of raised adenosine deaminase levels in CSF, and second clue can come in the form of when you collect the CSF and put it in a test tube and make it stand waiting for the analysis, you may also notice that a proteinaceous material forms a web-like structure which you call as cobweb formation. Cobweb formation. So these are potential clue towards tubercular meningitis in a MCQ. So what is this cobweb formation? So if the CSF is collected in a test tube, if it is collected in a test tube, let us say this is the CSF that I am looking at. Within this CSF, when it is standing there for some time, we will have some proteinaceous floating web-like debris, and this debris is what we call as the cobweb. So there may be cobweb formation. Okay. Similarly, what potential clues I can get for the Fungal meningitis in a CSF based question. If it is fungal meningitis, particularly most common one being cryptococcal meningitis, right? For the cryptococcal meningitis, the first clue you will get is that there is a negative staining called as India ink preparation, and India ink preparation may be positive. India ink preparation may be showing capsulated organisms, that is cryptococcus. That may be positive. Or second potential clue may be cryptococcal antigen being positive. Cryptococcal antigen being positive. So these additional clues often come in the CSF based MCQs. So latching on to the principles that we discussed, the basic CSF interpretation, and coupled with the additional clues, you should always be able to reach the right diagnosis in the MCQs as well as your clinical cases. Okay, so now we know how to diagnose the etiology of the meningitis. Now let us talk about the management of meningitis. So before I go into the management, let's quickly recap all the key points that we have discussed. So what is meningitis? Meningitis is inflammation of the meningeal layers. Inflammation of the meningeal layers. It could be infectious or non-infectious. Infectious carries high mortality. The infectious causes can be divided into bacterial, viral, fungal, and tubercular. Among them, the highest mortality is with the bacterial. This carries the worst prognosis. Among the bacterial, the most common cause is streptococci, followed by meningococci, followed by the staphylococci, MSSA as well as MRSA combined together. Okay. Apart from that, in selected set of patients like elderly or hospital exposed individuals, Listeria monocytogenes, and then in hospital exposed individuals or patients with penetrating head injuries, Pseudomonas aeruginosa can be a additional organism of concern. Fungal meningitis typically occurs in individuals with risk factors, which is primarily immunocompromised state, HIV with CD4 less than 200, poorly controlled diabetes, patient on immunosuppressants or cancer chemotherapy, or cancer patients. All of these patients present with a classical meningitis triad where you have headache, fever, and neck stiffness, which is seen in around 80% of the patients. But absence is very common in HIV patients, patients on steroids or immunosuppressants. That's why absence of symptoms of meningitis actually does not rule out meningitis. We need to have a high index of suspicion to detect meningitis. When we are suspecting meningitis, we subject them to examination. On examination, primarily we are looking at signs of meningeal irritation. Signs of meningeal irritation are not specific to meningitis. They can occur in any condition where there is meningeal irritation. Two signs are particularly important. In both these signs, we are trying to stretch the irritated meninges, and as we stretch, it triggers the pain. Patient does some compensatory physical maneuvers to reduce the pain. So first one is Kernig sign. Here we are stretching the spine from the foot end by trying to extend the knee from 90 degree onwards. We will find it difficult to go beyond 135 degree because the meninges get stretched, triggers the pain. Either patient complains about the pain or try resisting the further extension. In Brudzinski, we ask the patient lie down, and instead of stretching the spine from the foot end, we try to stretch it from the head end by flexing the neck. As we flex the neck, spine gets stretched, meninges get stretched, it irritates and triggers the pain. Patient tries to shorten the meninges or the spine by flexing at hip and flexing the knee. Indirectly, I can say that he is trying to withdraw the limb so that the spine gets shortened and the pain reduces. This we will call it as positive Brudzinski sign. So if these are positive, we are considering that meninges are irritated in the context of fever, neck stiffness, and headache. It's highly suggestive of meningitis. We will investigate now for the etiological diagnosis. The investigation of choice is going to be the lumbar puncture for CSF analysis, but many patients with meningitis will have raised intracranial tension. So before I put the needle, I should make sure that the intracranial tension is not elevated. So for that, we have to go ahead with the investigation. I should either do CT or MRI brain or fundus examination. The preferred investigation is CT or MRI. If imaging is not feasible or it is likely to consume time, then you can go ahead with the fundus examination. Once you have made sure that the ICT is not raised, we will go ahead with the lumbar puncture for CSF analysis. Once we get the CSF analysis, we will have a stepwise approach to interpret it. First thing I should see is the cell count. If I see cell count in thousands, it's most likely pyogenic or bacterial. But if I see cell count in hundreds or tens, it could be any of these. In that case, I have to look at the differential count. In bacterial, we see neutrophil predominant, means more than 50% cells are neutrophils. In viral, fungal, tubercular, we have lymphocyte predominant, means more than 50% cells are going to be lymphocytes. After that, if I'm unsure about the diagnosis yet, then I can look at the protein and CSF glucose. CSF glucose is normal for the CSF is 60% of blood glucose. Anything less than that is considered low. Low CSF glucose is typically encountered in bacterial, very rarely in fungal, but very often in tubercular. So this also has a differentiating role, helps us to differentiate different types of meningitis. By this time, you must have a possible diagnosis in your hand. If not, you're still stuck. These additional clues may help. If ADA levels in the CSF is elevated, it is pointing towards tubercular, or if there is cobweb formation in the CSF, it's pointing towards tubercular. If India ink preparation detects capsulated organisms, it is pointing towards cryptococcal fungal meningitis, or if the cryptococcal antigen is positive, it is pointing towards cryptococcal fungal meningitis. By this time, you should have a clear diagnosis whether you're dealing with bacterial, fungal, viral, or tubercular meningitis. Once we have the diagnosis, it's time about the management. And when we are talking about management, first statement I want you to remember is that bacterial meningitis carries very high mortality. Bacterial meningitis carries very high mortality. How high? Bacterial meningitis mortality is more than 20%. What does that mean? If I'm treating 5 patients of meningitis, 5 patients of bacterial meningitis, if I say mortality is more than 20%, that means at least one out of these 5 may not make it. I may end up losing that patient. I may be able to salvage only 4 of them. So that's very high mortality. So today, if someone lands up in a hospital with myocardial infarction, like we may not be getting this much of mortality numbers. Because of the angioplasty, we have much better mortality numbers for even myocardial infarction. So it is more than 20%. So now with this context, let me ask you a question. If I get a patient with meningitis, and as of now, I don't know whether it is bacterial, fungal, viral, or tubercular, and my lumbar puncture is going to take some time, because the doctor on duty is an intern or a JR, he doesn't know how to do lumbar puncture, and CT is also not available. My intern doesn't know how to do fundus examination. Should I wait till next day to get a CSF sample taken and then decide whether it is bacterial, viral, fungal, or tubercular, and then start the antibiotics, or सीधा antibiotics start करना है? Single icon, of course, you will be in the prayers of all the NEET PG division teachers, and hopefully you should crack. I would like to see you on the other side attending our classes. Yes. So rule number 1, if you can get the lumbar puncture done before giving the antibiotics, good. If not, go ahead and start the antibiotics. So most of the patients presenting with acute meningitis are bacterial. Most of the patients presenting with acute meningitis are bacterial. So you should start antibiotics without waiting for the lumbar puncture. So for all, because every 1 hour delay in initiating antibiotics, the mortality rate keeps going up and up. So if I delay 4 or 5 hours, I've already pushed the patient towards death. The risk is quite high. So I can't delay, right? So for all patients with acute meningitis, usually acute is bacterial and viral. Fungal and tubercular generally presents as subacute or chronic. So for all patients with acute meningitis, the first dose of antibiotics should be given should be given within 1 hour of presentation. Under 1 hour of presentation. What does that mean? Patient at a hospital. As soon as patient came to the hospital, patient comes now. Within next 1 hour, the first dose of antibiotics should be administered. If LP can be done before that, well and good. If not, give the antibiotics, do LP later. LP results may be interfered by antibiotics, but life is more important than me knowing what is the cause. So first dose of antibiotics should be given within 1 hour of patient presenting to the hospital. So when we are starting in many circumstances without knowing whether it is bacterial, fungal, viral or tubercular, of course I won't be knowing what is the organism responsible. So in that case, जो भी antibiotics हम start कर रहे हैं, whatever antibiotic I'm starting is empirical. I don't know the organism. So then whatever antibiotic I'm going to choose should be covering the common organisms, and this is where MCQs are coming from. Like they give the context, ask you to choose the empirical cocktail of antibiotics. Okay, so before I talk about antibiotics, let us again recap the bacteria that are responsible. What are the common bacteria that are responsible? Pneumococci, meningococci, staphylococci. So whatever blindly antibiotic I'm starting now should be covering these three organisms. Which antibiotic can cover the staphylococci, the pneumococci and meningococci? This is well covered by usually third generation cephalosporins. Like for example, ceftriaxone. That's why whenever you read about meningitis, one of the drugs they mention is ceftriaxone, because these take care of these two common organisms. But ceftriaxone may not be effective against MRSA particularly. But for this, what antibiotic I should add? Very good, very good. Crazy loser, quite good, good. So for keeping in mind that MRSA is on the rise, for this organism, that is Staph aureus, I should consider adding vancomycin. Vancomycin. So for all patients of meningitis, if I'm starting antibiotic empirically, it should include a third generation cephalosporin and vancomycin to cover these organisms. But what if I tell you that the person I'm seeing is 70-year-old? Don't you think I need to also take care of Listeria Listeria monocytogenes in that person? These two are for sure, because these are common. So these two antibiotics are required. But what if the age is more than 55? Then I also had to cover this. Do these antibiotics work, the ceftriaxone and vancomycin, for Listeria monocytogenes? No. What is the drug of choice for Listeria monocytogen? Drug of choice for Listeria monocytogenes. The drug of choice that effectively works against this is ampicillin. It is ampicillin. So if the age of the individual is more than 55, I might have to cover with ampicillin. Very good. Sir, Malayali ano. Malayalam manasilavum, but I'm not a Malayali. I'm a Kannadiga with Marathi ancestry. Okay. Next, Pseudomonas aeruginosa, hospital acquired organism, right? Most of the common antibiotics don't work against this, so it's a pain when we are dealing with hospital acquired infections. Pseudomonas aeruginosa is a pain. Which antibiotics work against Pseudomonas aeruginosa? In the hospital, when we have surgical site infections, right, we generally consider using piperacillin tazobactam or ticarcillin. But because these drugs have poor blood-brain barrier penetration, they're not good for meningitis cases. What else I can use? Yes, the fourth generation cephalosporins, like for example, ceftazidime, or carbapenems like meropenem. So if patient had recent exposure to hospital or penetrating head injury, I might have to use fourth generation cephalosporin or carbapenems like meropenem. So this is what I need to know. So now tell me, if I get a patient with meningitis and I need to start empirical antibiotics, what information I want to know? Whether this patient had any exposure to hospital. If there is hospital exposure, definitely I need to cover these two organisms. In that case, I need ampicillin. I might need a 4th generation cephalosporin, right? At the same time, I should also know the age of the person. If it is elderly, I definitely need to cover Listeria monocytogenes. I need to add ampicillin, right? So I'll give you a protocol. This will definitely help you to deal with real patients as well as all the MCQs related to the empirical choice of antibiotics. तो हम क्या करेंगे? We will divide the patients of meningitis into two baskets. Divide the patients of meningitis into two baskets. The first basket is community acquired meningitis. I will call it as community acquired meningitis. What do I mean by that? These patients have no recent exposure to hospital. Community acquired meningitis. And then the other basket, we will put healthcare associated or hospital acquired. Either patient had frequent hospital visits, or he was hospitalized, or he had penetrating head injuries. Because in all these cases, there is a risk of Pseudomonas as well as Listeria monocytogenes. So I shouldn't be thinking about Pseudomonas in patients with community acquired meningitis, because Pseudomonas is primarily a hospital acquired organism, but Listeria is still a concern. So in a community acquired case, I will look at the age of the person. If the age is more than 55 years, or if the age is less than 55 years. So in an individual aged less than 55 years, what are the concern organisms of concern? Most common cause for the meningitis is what? The most common cause for the bacterial meningitis is pneumococci. Second most common cause is meningococci, Neisseria meningitidis, and these two organisms are covered by ceftriaxone. And the third most common is staphylococci. For that we need vancomycin. So that's why for most community acquired meningitis patients, our treatment is going to be a combination of ceftriaxone, which is a 3rd generation cephalosporin, which will take care of pneumococci, meningococci, and I would require vancomycin to take care of the staphylococci. But once we talk about an individual aged more than 55 years, we have an additional concern. So what is that additional concern which was not there in individual aged less than 55 years? That is Listeria monocytogenes. That's an additional concern in these patients. That is Listeria monocytogenes. And what's the antibiotic of choice for that? Ampicillin. These will continue to be a concern in a person aged more than 55 years. So definitely I need these antibiotics, but additionally I need to add ampicillin to cover for the Listeria. So in these cases, we are going to treat them with, my treatment here will be ceftriaxone to cover the two most common organisms, plus vancomycin to cover for the staphylococci, but plus to cover for the Listeria, I would require ampicillin to be added. Now, when I switch to the healthcare associated or hospitalized individuals or penetrating head injuries, these all are concerned, that is pneumococci, meningococci, staphylococci and Listeria, and we have an additional concern added to this, and that's going to be Pseudomonas. So now I have to choose an antibiotic that takes care of all these organisms. So either I can think of a 4th generation cephalosporin to cover for Pseudomonas or carbapenem. Now I have a question. If I am bringing in a 4th generation cephalosporin, do I need to continue ceftriaxone? Or if I am bringing in a carbapenem like meropenem, do I need to continue ceftriaxone for pneumococci, meningococci? The answer is no, because the 4th gen cephalosporins as well as carbapenems have equally good or sometimes higher efficacy over these pneumococci, meningococci. So what we will do, we will ditch ceftriaxone. In that place, we will bring in a 4-gen cephalosporin or carbapenem. We will continue vancomycin for the staphylococci because neither 4-gen cephalosporin nor carbapenem have great activity against MRSA. Vanco is needed. We know that it is the drug of choice. And again, for the Listeria, I need to continue ampicillin. So here our treatment will focus on. So the first major change we are doing here is, instead of the 3rd generation cephalosporin, we are bringing in a 4th gen cephalosporin or carbapenem. So that 4th generation cephalosporin example I am quoting here is ceftriaxone. In your pharmac book, you may ceftazidime. In your pharmac book, you may get multiple examples. You should choose the one with good blood-brain barrier penetration. Either I can use ceftazidime, or again among the carbapenems, meropenem has excellent blood-brain barrier penetration. So that would be my choice of carbapenem, right? Plus, of course, I will require to continue vancomycin. I would require to continue ampicillin for the Listeria monocytogenes. So for most individuals, 2 drugs, that is ceftriaxone, vancomycin, but elderly, ampicillin comes to cover for Listeria. And if there is healthcare associated, hospital acquired or penetrating head injury patient, the 3rd generation cephalosporin gets kicked out by 4th gen cephalosporin or carbapenem to accommodate for the Pseudomonas. Rest, vanco and ampicillin, we will continue, right? Now try to apply this algorithm to whatever NEET PG Q bank you have, and you will hit the right answer. One important disclaimer, whatever we have discussed today about meningitis applies only to adult patient. You cannot extrapolate this to pediatric cases because their set of organisms are different, their choice of antibiotics will be different, their approach will be different. Now the question is, we started empirical antibiotics, but the CSF report came and it says it is viral. Should I continue the antibiotics? No. If it is viral, you can stop the antibiotics. If it is fungal, stop the antibiotics. If it is tubercular, stop the antibiotics. But to make sure that we don't lose out these individuals to high mortality, I want to start the antibiotics within 1 hour empirically. Once the report comes and it confirms that it is not bacterial, I will definitely stop giving the next dose. But if it is bacterial, I would be so pleased that because I started well in time and now my efforts are helping reducing the mortality risk of the patient. Okay. Now once we have started this empirical antibiotics based on the culture report and the sensitivity pattern, you can revise. If the sensitivity pattern says that ceftriaxone is not sensitive, it is showing some other antibiotic as sensitive, you can definitely revise. This is only the initial empirical choice. I will not be repeating it again and again. Now onwards, whenever in medicine class we say empirical, it's like we are blindly starting, but once the culture comes, we will be guided by the culture. So it doesn't mean that I have started this initially, I should continue the same antibiotic throughout the course. Okay. Once we have started and we have modified according to the culture, what should be the duration of antibiotics for the bacterial meningitis? Duration of antibiotics for bacterial meningitis. What should be the duration? The duration is 10 to 14 days. The duration is 10 to 14 days. So after completing 10 to 14 days of antibiotics, I can't just say that 10 to 14 days is done and the meningitis treatment is over. No. Once I've completed 10 to 14 days, it should be followed by a repeat CSF analysis to prove that the CSF abnormalities have resolved and no more evidence of active infection is present. So the repeat CSF analysis should be done. If the repeat CSF analysis shows that still the cell count is elevated, protein is elevated, that means the infection is still not eradicated. In that case, you might have to continue the antibiotics further. So you have to make sure that repeat CSF analysis is done to prove eradication of infection. Only when the repeat CSF comes normal, then I am sure that I have treated meningitis effectively. Till that time, it's not proved that meningitis is cured. Okay, clear? Now, what if the CSF report had showed that it is viral? How do I proceed further? Bacterial, good. I had started empirical. I will continue that till I get the culture report, and based on the culture report, I can modify my antibiotics. But what if it is viral? Most viral meningitis are self-limiting, so we will try to treat them symptomatically. Means they have pain, fever, right? So give NSAIDs, antibiotics, take care of it. But studies have shown that if we give IV acyclovir, the duration of illness, as such, viral meningitis does not have very high mortality except few organisms. But studies have shown that if you give acyclovir, the duration of illness gets shortened. Like if, let us say that I would be okay if I have viral meningitis, maybe I would be okay after 5 days. But if you give me acyclovir, maybe I will be okay by 4 days or by 3 days. No impact on mortality per se, but IV acyclovir decreases duration of illness. Duration of illness. Whether that mattered to the patient or not, based on that we can judge whether we should give IV acyclovir or not. Okay. And what if it is fungal meningitis? If it is fungal meningitis, which is most commonly cryptococcal. So what is the drug of choice for cryptococcal meningitis? So the treatment of choice for cryptococcal meningitis. See, when it comes to cryptococcal or fungal meningitis, one point I want you to know that these patients have profound risk factors for the fungal meningitis, that is like HIV with CD4 count low, or cancer chemotherapy, or an immunocompromised state for some other reason. So even if I give antifungals and eradicate the fungal infection, because they have low immunity, it will come back again. It will come back again. So we might have to give them preventive treatment. We might have to give them preventive treatment. So the treatment of choice is going to be, if they ask you specifically what is the drug of choice, it is going to be amphotericin B. And because we know that amphotericin is nephrotoxic, we should prefer liposomal amphotericin B. So liposomal amphotericin B plus flucytosine. Flucytosine. That's going to be the treatment of choice for eradication of infection. But they may also ask you, what is the treatment of choice or drug of choice for maintenance or preventive treatment? Because once I have eradicated, as long as the risk factor or low immunity is there, the infection will bounce back. So for that, the drug of choice is fluconazole. So you can give oral fluconazole to prevent cryptococcal meningitis from coming back. The next question is, how long should I give? Should I give, like, this is for eradication, but after that fluconazole for, let us say, HIV with CD4 count 100 coming with cryptococcal meningitis. So I started amphotericin B, flucytosine, cryptococcal meningitis resolved. Now I have switched to fluconazole. How long should I give fluconazole? Lifelong, 10 days, 2 months, 6 months. Fluconazole should be continued as long as the immunocompromised state continues. If it is a cancer patient on chemotherapy, as long as he is receiving chemotherapy and immunocompromised, we have to continue, right? So in the context of HIV is where they ask MCQs. In the context of HIV is where they ask MCQ. So I want you to remember that the fluconazole should be continued till CD4 count is less than 200. Once the CD4 count crosses 200, it may come again drop back, right? So I will withdraw fluconazole only when CD4 count becomes more than 200 and sustainably stays more than 200 for at least 6 months without dropping below 200, then I can withdraw. So when I can withdraw? So this should be continued for 6 months after CD4 is count is more than 200 sustainably, means it is remaining more than 200 for at least 6 months, then we can withdraw the fluconazole. Okay, now how am I going to treat a case of tubercular meningitis? Of course, it is ATT. Treatment of tubercular meningitis will be with anti-tubercular therapy. The details of ATT regimens and all we will discuss when we take up a case of tuberculosis. Okay, so to summarize, how are we going to treat a case of meningitis? As soon as we detect that it is a case of meningitis, if it is acute, it is most likely bacterial or viral, and any case of acute meningitis, there is a very high mortality if it is bacterial. So we need to give the antibiotics within 1 hour, and when we are giving within 1 hour, we may or may not have the LP report available. So we start antibiotics empirically. When we are starting empirically, we take this context. This context helps us to predict which organism may be responsible. Accordingly, we will make an initial choice. Once we have initiated, we will continue till the CSF analysis report is available. CSF analysis report says it is not bacterial, you can withdraw. If it is bacterial, you will continue till the culture report is available. And once the culture report is available, if culture sensitivity pattern says whatever initial choice you have made is not the right, you can revise it. If it is right, you can continue it. How long I should continue? I should continue for 10 to 14 days. At the end of 10 to 14 days of therapy, especially for Pseudomonas, we go for 14 days. Other organisms, 10 days. We have to stop antibiotics only when after completing the course, we have done a repeat CSF analysis and it is clean. Only then you can stop antibiotics. For the viral, mainstay of treatment is symptomatic, but if you want to cut short the duration of illness, you may consider giving IV acyclovir. For fungal, we treat them with liposomal amphotericin B and flucytosine, but because these patients have a risk factor of acquiring it again, we might have to give them a preventive treatment. For that, drug of choice is fluconazole. Fluconazole should be given as long as the immunocompromised state persists. For an HIV patient, we will withdraw fluconazole once the CD4 count remains elevated more than 200 for at least 6 months. Okay, clear? Now, one last question. Is there any role of steroids in the management of meningitis? So another important thing I want you to know is that if you have a patient with meningitis and even if they recover, like they survive meningitis, he is not one of those mortality cases, it's a survivor. Even in survivor, it leaves behind some damage. We will call it as post-meningitis sequelae. Crazy loser, very good. Among them, the common complications are patients often develop cognitive decline, in the sense their thought process, attentiveness, memory, these take a hit. Because when we had meningitis, body produced inflammatory cytokines like interleukin 1, interleukin 6. And these inflammatory cytokines go and cause the inflammation of the meninges. But the spillover effect, we also cause inflammation of the neurons. That's why we are getting that cerebral edema. And that inflammation of the neurons may end up damaging some of the neurons. That damage, as we know that the dead neurons are dead neurons, we cannot recover them back. So you may have some neurological functional loss. So if the neurons that get affected are related to higher mental functions, you will have cognitive decline. So cognitive decline is one complication. Second, very often these patients develop sensory neural hearing loss. Right? So steroids are known to decrease, because if I give steroids, I reduce the inflammatory cytokines. So inflammation of meninges and the brain comes down. And if that comes down, the damage of neurons also comes down. A common argument, sir, if we give steroids, we will blunt our immune system. So our fight against bacteria will come down. The answer is no, because bacterial battle is taken care by antibiotics. We are hitting them hard with a good choice of antibiotics. So bacteria are killed by antibiotics. We will prevent the immune mediated damage to our own brain with the help of steroids. right? So there is something called as post meningitis sequelae. There are plenty of them. The common ones that an undergraduate student need to remember is cognitive dysfunction or decline in the higher mental functions. And the second one is going to be sensory neural hearing loss, particularly more common with bacterial meningitis, particularly more common with select set of bacteria. Okay. Common in bacterial meningitis. And steroids decrease the incidence. Steroids decrease the incidence of post meningitis sequelae. So it makes sense to give steroids. So there's one question now. What should I give first? Like we have to give antibiotics within 1 hour. Should I give the antibiotics first or steroids first? Soumya, thank you. Thank you. Crazy loser, very good, very good. Yes, the dexamethasone is the steroid of choice. The question is, what should go first? Antibiotic first or steroid first? Okay, so let me tell you exactly what is happening. So if there is meningeal inflammation, right, meningitis, basically meningitis means first thing that starts is infection. So when infection happens, the bacterial cell wall products are now there in the blood, right? So there is bacterial cell wall products in the blood. Our immune system recognizes the cell wall products, and the cell wall products now trigger our immune system to produce inflammatory cytokines like interleukin 1, interleukin 6 and all. These on one side they cause meningeal inflammation, that's what we call as meningitis, and the second side they cause the post meningitis sequelae, means they're also going to cause inflammation of the neurons, and that is going to cause the damage. So it's going to cause this post meningitis sequelae. So the first thing we should actually give is not antibiotic. Within 1 hour we should give antibiotic, but even before that ideally we should give a dose of steroid. Give steroid first, then start antibiotics. You may be wondering, what is the logic, sir? Because whatever antibiotics we use today for treatment of meningitis, they're all bactericidal. They break down the bacteria, they kill the bacteria. They're not bacteriostatic. They're not stopping them from replicating, they're breaking it down. So antibiotics break down and kill more bacteria, so they increase the amount of bacterial cell wall products, and they will trigger like lipopolysaccharides. Like just to give you an example, like lipopolysaccharides. So they will stimulate production of interleukin 1 and 6 more, and that will increase the meningeal inflammation more, and it will also increase the risk of post meningitis sequelae. But instead, if I give steroids first, the steroids will block our immune cells. Steroids will block our immune cells from producing IL-1 and IL-6. And after that, if I start killing the bacteria, these increased cell wall products will not be able to trigger our immune system to make more IL-1, more IL-6. So the chances of developing post-meningitis sequelae comes down, right? So that's why the first dose that goes into the patient's body is going to be steroid, followed by antibiotics. Ideally, steroid should be given at least 15 minutes before the first dose of antibiotics, if not along with antibiotics. Definitely not after antibiotics. If I give after antibiotics, already antibiotic is given, it has broken down the bacterial cell, and the bacterial cell wall products would have stimulated your immune system, and your immune system would have made a lot of inflammatory cytokines, and this damage would have started. So I don't achieve what I wanted to achieve with the steroids, right? I hope you understood what I'm trying to say. So then the first dose of steroids should be given 15 minutes prior to 15 minutes before antibiotics. If not possible, then you can give along with the antibiotics, but avoid initiating after the antibiotics. And what is the steroid of choice that we are talking about here? It is going to be IV dexamethasone, right? 2 to 4 milligrams every 6th hourly for 4 days. That means we are giving antibiotics for 10 to 14 days. We are not continuing steroids for all 10 to 14 days. We are giving it for only initial 4 days, not beyond that. Clear? And antibiotic goes for 10 to 14 days, steroid for only initial 4 days. During this time is where maximum immune mediated damage to our own neurons happens, right? So another thing that I wanted to know here is that the steroids are useful not only for the bacterial but also for tubercular meningitis. So steroids are recommended for bacterial and tubercular meningitis patients because both have post-meningitis sequelae. For bacterial and tubercular meningitis, right? So now we have a clarity that the first thing that I give to my suspected or confirmed meningitis patient in the emergency room is IV dexamethasone. 15 minutes later, the first dose of antibiotics. In that antibiotics, I might have, depending on the age of the individual and the context, whether it is community acquired meningitis or there was an exposure to healthcare or penetrating head injury, I will choose a cocktail of antibiotics, 2 drugs or 3 drugs. Once started, I will continue for 10 to 14 days, steroid for 4 days, right? Hopefully at the end of 10 to 14 days, I will end up with a patient who does not have any post-meningitis sequelae and the LP comes out clean. Then I can declare that the treatment of meningitis is successful. The patient will get discharged. If the case was fungal meningitis, once the fungal meningitis resolves, I will discharge him on fluconazole oral for prevention. He will take the oral preventive treatment till his CD4 count normalizes, that is at least it becomes 200 plus and remains 200 plus for at least 6 months. He will be on fluconazole. Once he has spent 6 months with a CD4 count more than 200, then we can withdraw the fluconazole. The antiretroviral drugs will be continued. So that's it from me today. Please solve the MCQs on the meningitis chapter today, because in whatever twisted way they can ask, we have addressed. So hopefully your concepts are clear and you should be able to get those questions right. If you feel you're stuck in any question or any question's answer is not in alignment with whatever we have discussed, ping me on the Instagram. In the next Read Harrison, first I will address your queries and then we'll start with the topic, right? That's it from me today, guys. Study well. All the best. See you soon. Bye-bye. Good night.